So, greetings to all and thanks to Profound for the opportunity to present our results in this webinar. My name is Mikael Anttinen and I work as a urologist at Turku University Hospital. I work mainly with uro-oncological cancers, but I also treat patients with lower urinary tract symptoms and perform also conventional TURP procedures. I am currently finalizing my doctoral thesis on novel imaging and imaging-guided therapies in prostate cancer. I've been working now for over 3 years on TULSA research, and I've been involved in every TULSA treatment at our center. We have been treating various prostate conditions with TULSA since 2017 as a part of our research project, and we have currently treated 115 patients with this method. So today, the current gold standard in the treatment of benign prostatic obstruction is transurethral resection of prostate. It is associated with well-known adverse effects, including the risk of intraoperative bleeding and the ongoing use of anticoagulants compounds these risks. Adverse effects include also transfusion risk, urethral strictures, recatheterization due to retention, urinary urgency, and increased mortality predicted by age and comorbidity status. So there is a clear unmet need for safer and mini-invasive treatment methods for BPO. So, based on our previously published studies on focal, palliative, and salvage TULSA, we have demonstrated that TULSA enables personalized and flexible ablation of prostate tissue. The flexibility of TULSA in the context of BPH is illustrated here in the figure. The method allows ablation to be deployed anywhere the prostate, either whole gland or focal. And TULSA is suitable for treating rather large prostates over than 80 cc, and it can be customized based on patient's preference, taking into account individual anatomy, enabling, for example, ejaculatory duct sparing ablation and also proactive ablation of concomitant other lesions in the prostate, for example, simultaneous ablation of concurrent prostate cancer. So, what evidence do we have so far on TULSA in the treatment of symptomatic benign prostatic hyperplasia? There is no prospective studies yet addressing this topic. There is only one retrospective study on 9 patients with symptomatic concomitant BPO in addition to localized prostate cancer, and those patients were evaluated regarding possible symptom improvement after whole gland TULSA ablation. This data stems from a phase 1 study by Chin et al., in which the safety and efficacy of TULSA in the treatment of local prostate cancer was evaluated in 30 patients. This retrospective analysis showed that at 12 months after TULSA, IPSS score improved by 58%. All 9 patients showed significant improvement in all symptom scores all patients maintained their continence, and prostate volume decreased by 70%, and there were no serious adverse events recorded in these patients. These preliminary results from the retrospective analysis suggest that TULSA could be used also to treat benign prostatic obstruction. So in our hospital, we have a prospective ongoing study assessing symptom relief after TULSA in a cohort of 30 patients. We have treated already 20 patients, and 9-month follow-up is completed. The study intervention is customized TULSA ablation, primarily targeted to the hyperplastic tissue. Efficacy and safety data are assessed by MRI, uroflowmetry, and a comprehensive set of questionnaires. MRI was performed at 3 months and 12 months post TULSA, and questionnaires includes EPIC-26, IPSS, and IIAF-5. Adverse events are recorded using Clavian-Dindo classification of surgical complications. Also, patients' medication use and PSAs are monitored. The baseline characteristics of this study population are shown here. The median age is 67 years, the median prostate volume 53 cc, and PSA 4.4. 2 patients received anticoagulants which were not discontinued before the treatment. Baseline MRI showed 3 PIRATS 3 lesion and 1 PIRATS 4 lesion, and this patient underwent systematic and MRI targeted biopsies which were negative for cancer, and this patient was enrolled to the study. 9 months follow-up data has now been completed in every study patients. As these figures show, the median IPSS symptom score decreased from 17.5 at baseline to 4 at 3 months and stayed stable to 12 months. At 6 months, 9 out of 10 men achieved IPSS decrease greater than 30% from baseline. Median IPSS quality of life score decreased from 4 at baseline to 1 at 3 months and 0.5 at 12 months, meaning that at baseline patients were mostly dissatisfied and at 6 months mostly satisfied. And here we have the results from erectile function and prostate volume. The median prostate volume decreased almost 40% at 12 months. And as you can see here, based on IIAF-5 questionnaire, the erectile function was stable through 12 months. And here we have the results of uroflowmetry. Both the Qmax and post-void residual volume improved between baseline and 12 months. The median Qmax improved almost 73%. 3 out of 10 men had Qmax more than 15 milliliters per second at baseline, and 10 out of 10 at 6 months. and 6 out of 10 men had PVR less than 100 milliliters at baseline, and 8 out of 10 at 6 months. And here are the results from EPIC 26 urinary domain, and it shows that incontinence was unchanged at 12 months, and there were clear improvement in terms of obstructive and irritative urinary symptoms at 12 months. So here we have a couple of cases. This case number one is 63-year-old man who had severe benign prostatic hyperplasia symptoms and had maximum medication, which means that he had alpha blockers and 5-alpha reductase inhibitor. The treatment plan treated the hyperplastic tissue from the apex to base, extending into the bladder neck, and no complication were seen, and erectile function maintained good. And the IPSS score improved at 3 months and were stable to 12 months. And there on the right upper corner, we can see the table where we see the IPSS quality of life and Qmax, and also PVR and IIAF5. And we can see in every questionnaire and uroflowmetry parameter that there was clear improvement. And below in the upper panel, we can see the targeted area where the yellow boundary covers the area where the hyperplastic tissue is located, and below that you can see MRI thermometry maps that shows good thermal coverage of the treatment area. Case number 2 is an interesting case. We are talking about 65-year-old man who had severe PPH symptoms and maximum medication for these symptoms. And in our study protocol, we plan to do targeted ablation to the whole adenoma area, but this certain patient wished that his ejaculatory duct would be spared, and we didn't know at that point that it is possible, but we tried. And here we can see in the bottom images how we planned the treatment area. We have covered the whole transitional zone, but left the area where ejaculatory ducts are located outside the treatment field. And as you can see here, we have succeeded well with TULSA. The dermal coverage is reaching the boundary, and after the treatment, the patient had normal ejaculatory function, meaning that he had undergrade ejaculations. And in terms of other parameters, there was clear improvement shown, as you can see from the table in this slide. IPSS score improved 78%, and his maximum flow rate improved more than 3-fold, and erectile function was also maintained. And here we have case number 3, and this patient was 56 years old and had also medication for lower urinary tract symptoms. His PSA was 3.7 and he had also pyrite 3 lesion. This patient had undergone once biopsies, systematic and targeted biopsies, and they were negative. And patient wished that we include the pyrite 3 lesion also in the treatment field, and we performed as he wished the TULSA procedure and targeted both the adenoma and the pyrite 3 lesion. And again, no complication was recorded and erectile function maintained. And at 12 months, post-TULSA MRI and biopsies were negative for cancer. And in the table, you can also see in this case that almost in every parameters, the clear improvement was seen. And in this table, which is adapted from Elterman et al. From the paper that was published in Journal of Endourology, and our results are contextualized with the results of other methods from pivotal or randomized controlled trials, and compared to the other methods, TULSA seems to do quite well based on functional results. And conclusions: TULSA appears technically feasible therapy option for BPO. Urinary function improved substantially during the initial 9-month follow-up among all 10 patients, while no adverse effects were seen on sexual or bowel functions. And the application of these results in larger cohorts would offer men with BPH a safe and effective treatment for BPH, which can address unmet clinical needs. And flexibility of TULSA has been demonstrated for large prostate, ejaculatory duct sparing, and ablation of concurrent prostate cancer. We have just expanded our patient cohort to include 20 extra patients to further evaluate the efficacy of TULSA in the treatment of benign prostatic obstruction. Thank you.